switch the lights, please?
Good morning, I'm Dr. Duke Majan, and today is January 10th or 11th? 10th, sorry, 2023. We are broadcasting spine surgery from the Duke Spine Institute live and uninterrupted for your viewing pleasure. Please return to your seats, silence your cell phones, and bring your popcorn and Diet Cokes and sit down and get ready to enjoy a broadcast of spine surgery. Now, this patient has back pain, and the pain goes from the back into his legs. So he's got leg symptoms from pinched nerves or irritated nerves, and he's got a herniated disc at L3-4 on both sides. So we're going to go into the L3-4 and we're going to repair the annular tear where the herniation comes out of in the back of the disc. We're going to also remove the herniated disc. All right, so we're going to get started. Then at the end, we're going to do a Duke plasma rhizotomy for facet pain. But we're not going to be broadcasting that. We're going to get started. If you have questions, feel free to ask during the surgery or after, and I will be happy to answer them for you. So step one is accessing the proper disc, okay? And accessing the surgical directive or surgical target is the first part of any surgery. Of course, there's positioning of the patient on the table, prepping and draping, and the anesthesia, what's already done. But once you get to this stage where, you know, the surgical area is exposed and prepped and draped, then the next step is accessing, or what we call exposure. All right, so that's the sacrum down below. Show us the sacrum. You have the x-ray picture there, Henry?
Yes, we do.
You can see the white arrow. That's the sacrum bone down at the bottom. It looks like an ice cream cone. And then the L5, L4, and then L3. So our target is the L3-4 disc, and it's not just the whole disc, it's the back of the disc where there's a herniation there. Yeah, Jordan is doing a wonderful job of showing you. Now, Jordan, show us the neural foramen, where the nerve roots come out. The whole foramen. Yes, that's the foramen. It's that white area there, okay? And where does the nerve actually come out? It comes out at the top, just under the pedicle. Show us the pedicle of L3. That's correct. The nerve coming out of the spine right there is the L3 nerve root. And the L4 nerve root comes out below that. There you go. Perfect. So the L4 nerve root is passing by the back of the disc on its way to exit. Yep, and that's where the herniation is. You can actually see the herniation on the x-ray. Yep, that's it. It's huge on both sides. Okay, so that's what our target is. You can see the needle is heading there. Thank you, Jordan. Great job today.
Thank you, sir.
Any questions from the audience so far? Shot?
No current questions.
So Arias, someday, hopefully you'll be doing these procedures. The key to avoiding nerve root injuries is to go into the foramen in the bottom half, where I'm going right now. Can you hear me, Arias?
He's giving the thumbs up, yes.
All right. So you see how the needle is in the bottom half of the foramen? Show me, shot. Shot. No, do a shot, yeah. So top half, Jordan, show us the top half of the foramen where the nerve lives. Yeah, we want to stay away from that area. That's where you get nerve injuries. And you want to stay in the bottom half. And it just so happens the herniation is in the bottom half anyway. Now the area we're entering is called Cambin's triangle, or Cambin's safe zone, sorry. And that's because Parvis Cambin, who's an orthopedic surgeon out of Pittsburgh, was the one who discovered this approach, this access, all right? And he's the first one to describe it. So the safe zone is the bottom half of the foramen. All right, let's get an AP view. I'm not done yet, but we're close. So far, things are looking good. How's our patient, doctor? Reliable? So you need your patient, that's perfect. You see the AP view, we're right at the back of the disc with the needle. Is he awake? All right. You okay? So this part of the surgery you want the patient awake for, and the reason is simple. if I get too close to that nerve root. And like I said, it's not just that the nerve's in the top half of that foramen, but the nerve is also, you need to look at the AP view to make sure you're not too lateral, because you could hit the nerve laterally as well. Shot? All right, so I'm a little lower than I want to be. And by the way, these needles can be directed because they have a bevel on the tip. And what that means is they actually can, the bevel will force the needle into a one direction. If you look at the pink thing right here, you guys see this, Henry? You see that little slot right there on the pink plastic part?
Yes, we do.
That tells you which direction the needle is going. As it enters, it goes away from this pink slot. It goes that way, away, the opposite. So if you want the needle tip to go more medial this way, you have to turn the slot that way so it'll aim the needle tip more medial. If you want the needle tip to go inferior that way, then you turn the slot that way and the needle goes that way as you push it in, of course. And you can go any direction you want, and that's why I'm always twisting the needle. Sean? If you watch my hand as I'm going in, I'm feeling with the needle and I'm twisting to redirect the tip. So I'm too low there. I want to go further north. And what I'm feeling for right here is the facet. I want to feel that bone. Shot? When I feel the facet, that tells me that I'm in the right spot, and then I go around the facet. Okay, you see how I changed the direction of the needle there? All right. Shot? So both needles are very close to where we need them to be. Is he awake? AP? So before I go any further and get closer to where the nerve could be, and I'm not talking about the L3 nerve, I'm talking about the L4 nerve at this point. Because, huh? Yeah, no problem. That looks really good. That looks really good. All right. Everyone agree we're at L3-4, Luis? Yes, sir. You agree we're at 3-4? Yes, sir. So this particular patient, folks, has back pain coming from the L3-4 herniation, and he has leg pain coming from a pinched nerve right here at L3-4 in the lateral recess on both sides. So we're going to fix the L3-4 back pain from the disc and the leg symptoms by doing the Duke laser disc repair here. We're also going to do Duke plasma rhizotomy for facet pain on the right side at L4-5, L5S1, because he's having facet pain over here. So we're treating disc pain and facet pain. All right, Dr. Berndes, are we ready? I'm waiting for my anesthesiologist. He needs to make sure the patient's awake for this part, because if I get too close to the nerve, and that would be the L4 nerve root at this point, then the patient will tell me, oh, I'm having pain in my leg. And I need him to be able to tell me that, because if he can't tell me that, then I could end up damaging the nerve and not knowing it. So it's very important that the patient's awake for this particular part. Now, I'm just going to show you what I'm talking about. He's got the L3-4 disc right here. Okay? L3-4 disc. Remember, the disc is the cushion between the bones. This would be the L3 bone. And then below that would be the L4 bone. And this is the L3-4 disc. He's got a tear on the left side and a tear on the right side, and the jelly is squeezing out through the tear, and it's hitting the nerves, okay? The nerves actually come down and then exit through the holes I showed you. And because the L4, this is the L4 nerve root, that nerve is passing right behind the herniation at L3-4. Killing me. Don't move. All right. So we're going to test this disc and see if it's causing back pain. No. You don't want to tell the patient we're testing the disc. No, I'm not ready. I'm not in yet. Yeah. Yeah, I got to finish placing, but then we're going to test the disc. Yeah, that's all right. Are you awake? How's blood pressure? All right, so I'm just waiting for the patient to be awake enough to enter the disc here, and I just need him to be completely awake because he's my sensor. He's going to tell me if I'm too close to the nerve root. You know, the biggest risk of this surgery is there's a lot of risk that could happen. We could end up putting the metal pipe in somebody's stomach or intestines, and then that would be really bad. They would need emergency surgery to repair it. We could end up causing an infection. We could end up damaging a nerve root. These are all possibilities, spinal fluid leak. So to avoid the complications, you have to know how to get those complications as a surgeon. And you have to pay attention throughout the surgery that you're not endangering any of those structures. So for this particular surgery in the lower back, our patients are awake just for the beginning to make sure we're not too close to that nerve root. And that's my only way to know for sure.
Open your eyes. Yeah, perfect. Can you open your eyes? Good. Okay, Dr. Duke has some questions.
I need you to lay still, okay?
He's opening his eyes now.
Can you lay still for me? I'm going to place the first needle. Are you okay? Shot. Mm-hmm. I went into the tear. I could feel it. So we're inside the L3-4 in the tear. Are you comfortable?
How are you feeling? Are you comfortable?
Shot.
He said yes.
All right. No pain down your leg right now, right?
No.
Where do you have that pain right there?
Where's your pain?
What did he say? Where is the pain right there? Where is it?
Where's your pain? In your back or your leg? What's that? We can't hear you. Say it louder.
Sean.
No pain?
Are you having any pain?
You said no pain.
I gotta have them more awake, honestly. Gotta work on that. All right. Well, we're just gonna have to wait here another minute until he's completely reliable. Shot? Yeah, you gotta learn the balance of just sleepy while I numb them up, and then they gotta be reliable at this point. Lay still. So he's wiggling around a little because it's for him it's a little bit uncomfortable, which is normal. Shot. All right, so I'm a little bit more medial than I want to be. I know that from my AP. Shot. So I'm directing my needle more laterally. That's why I have this fin right here, pointing medial, which means it directs the tip lateral. Shot. So I'm just aiming and I want to hit that spot perfect. Shot. And see how it's lining up with the other needle even better now? That's where we want to be. Shot. I feel the herniation. I just touched it. Show us the second needle, the one I'm placing now, Jordan. The other thing, Jordan's going to show you the tip. There it is. That's where I just felt the herniation. That's where it's sticking out to. Now, Jordan, show us the back of the L3 vertebral body. You guys see how there's a double shadow there? One there and one there. Yeah, there's two lines. They go up. You see them go up? That means that our fluoro is not perfectly lateral to the vertebral body because he's moved. He's moved around a little bit, wiggling around a little. That's about 1 degree off. So you want to shoot through the back of the bone perfect. You want to look at the back of that bone and it should be lined up perfect. So Jordan will probably, there it is. That's perfect now. Okay? It's important, folks, you get the x-ray picture perfect before you place the needles. Otherwise, you'll be placing the needle somewhere you think you're going, but you're not. You're not in the right place. All right, so we're about to enter here at L3-4 on my side. Shot. We're in like Flynn. You're okay. Relax. All right. So now we have successfully navigated through the tear in the back of the disc at L3-4 on both sides. And we've avoided the nerve roots, so we're safe. We're not going to have any nerve injuries. because the patient would have told me. You comfy?
You doing okay, sir? Yes.
All right. Are you having any pain?
Any pain in your legs?
Anywhere. Yeah. Now he's responding, he's reliable, and we also need him reliable to do the discogram, because we're gonna want to know, is this a painful disc? Because that's, after all, one of the reasons we're here operating. You okay?
Doing okay?
So I don't tell the patients when I'm going to inject. I don't want them to know. See that? How bad is that on a scale of 1 to 10?
10? 0 to 10. 10.
All right, that's a 10 out of 10. Is that where you get your back pain? Yeah. He said yeah. So that was a 10 over 10 pain, guys. That is perfect. That is what we want, and it's concordant. What does all that mean, Guidewire? So this is important. Where does back pain come from? 99% of doctors will tell you they don't know where back pain comes from. But we just found where his back pain comes from. It's the disc, and it's specifically, Duke Spine Institute discovered it's a tear in the back of the disc. Also, notice over here how the blue dye is coming out of this needle. We didn't inject it in this one. We injected on this side, but it goes across the disc and out through this one. Pretty cool, huh? All right, now, this patient doesn't have blue blood. He bleeds just like the rest of us, but this is a bloodless surgery. All right, so that's another advantage of this procedure, is it's bloodless. We've already numbed up the skin, and we're ready to make our 7mm quarter-inch incision. The whole surgery, folks, is done with this tiny incision. That's it. And there's no internal damage to his body. All the other types of spine surgery being done today, will do damage to the body. That's why patients have to stay in the hospital. That's why patients have to take powerful opioid painkillers after their surgery, because the surgeon is jacking them up with the surgery. He's messing up their bodies. So this surgery is so painless afterwards because we're not damaging anything. Okay? The patients, they don't need painkillers. They take Tylenol for one night and maybe a muscle relaxer, one pill, and they're done. The next day, they're done taking pain meds. And they're up walking and going back to work. So rather than having open back surgery, fusions like this patient would have to have, he's having the laser surgery instead. Just relax, you're doing great. All right, Berndes. Everything's fine. You're doing great, just relax. I need you to count from 1 to 100 out loud. Can you count from 1 to 100? All right, so he's going to sleep right now. We're putting him to sleep. And once he's asleep, we'll proceed. So the part of the surgery with the patient awake is over. I don't need the patient awake anymore. You can see on the x-ray that I'm at the L3-4 disc, so we're at the proper level. One of the biggest things in spine surgery is surgeons make mistakes all the time and they operate on the wrong level because they don't count properly. It's very important, if you're going to do spine surgery in the lower back, you have to see the sacrum. The sacrum, or S1, is the most important landmark. It's the only reliable landmark. All right, we're now entering the tear where the herniation came out of. Shot? You're going to see the tear in just a moment. I'm going to show it to you. So I want you to pay attention. We're not removing any lamina. There's no laminectomy being done. There's no foraminotomy, no facetectomy, no ligaments or muscles being taken off the spine. We're literally spreading them gently. Now we're inside the tear. I'm going to go in a little further. Shot. With the dilator. You could see the dilator is in the middle of the disc. And now we're going to bring our final piece. The whole surgery is done through this beautiful little metal straw. This is endoscopic surgery, folks. This is the least invasive spine surgery in the world. There's virtually no bleeding. This is it, right? A few drops of blood. In spine surgery, we measure blood loss in milliliters, which a milliliter is 20 drops of blood. 1 milliliter, and most surgeons lose hundreds and hundreds of milliliters in a surgery. We're going to lose drops. So not even in the same zip code as most spine surgeries, okay? So this is bloodless surgery. It's no painkillers after surgery. It's outpatient, meaning this patient's going home. Jordan, show us the tube in the back of the disc. The tube has gone through the herniation. Yep. And as I work, I'm going to pull it backwards. What is it?
No, I'm just thinking if you want to do the other side.
At this point, folks, we're going to switch from the fluoroscope to the endoscope. And I just want to remind you how patriotic this patient is. You see? Red, white, and blue. It's true American. And if you're French, I guess it would be, what is it? White, blue, red? Any questions from the audience?
No current questions.
Let's show the audience, why do patients with a herniated disc get back pain? Why is back pain, how is it caused by a herniated disc? Blue towel.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back, and we're getting ready to start with the laser. The laser is that fiber you're looking at right in front of you. The glass part of the fiber is 1 millimeter, just gives you scale, 1 millimeter wide. And now we're going to start removing the herniation, which is the blue stuff. We're going to debride the annular tear. There's some more herniation there. Now you see the gold color, that comes from calcium. And calcium is found in damaged tissues of your body. It's called dystrophic dystrophic calcification. It's something that I was taught in medical school in pathology, and it's not unique to the disc. If you have damaged tissue anywhere, your liver, your lungs, a lot of times you'll see chronic inflammation and calcification. But this is an inflammatory disease we're dealing with, okay? What does that mean? What it means is that the pain people have come from inflammation inside the tear. And the tear is where we are right now. So we're cleaning out all the stuff that's causing the inflammation. And that's what causes people's back pain, is the inflammation. It's also what causes sciatica or leg pain, inflammation of the nerve root. Unfortunately, 99% of doctors don't know this. So if you're hoping to get these answers from your doctor, don't count on it. You're not going to get them. And most people live in pain because their doctor doesn't know how to fix their problem. At Duke Spine Institute, we specialize in curing back and neck pain. We do it through these advanced techniques that nobody else has. They're unique here for the most part. There are some doctors doing these around the world. I get emails and texts and comments from surgeons that are starting to do our technique in other parts of the world. Unfortunately, the United States has a lot of doctors that just want to do fusions and artificial discs because they pay very well. They're not motivated to do what's right for the patient. They're motivated to do what's right for themselves. All right, take a look there. What is that metal? Anybody know? Well, that's the needle from the other side, right? Because remember, we're doing both sides of this disc. So I had to put 2 needles in, one on the right, one on the left, and that's literally the needle on the other side, okay? And I just have to work around it. But you can see the laser has hit the needle. What has it done? It's melted it. Okay, so people ask me, Dr. Duke, can lasers remove bone spurs? Of course they can. They can melt steel. You can remove bone spurs. Steel is harder than a bone spur. So can a laser be used to remove bone spurs that are necessary to remove? Absolutely. Does that mean we're going to remove all the bone spurs? No. Why? Because most bone spurs don't need to be removed. All right, so as I pull back, you can see the tear. This is the tear in the annulus where the herniation has come out of. And you can see parts of the herniation, the blue stuff, still in the tear. And I have to try to remove that so that this will heal. It's amazing that this patient, how old is our patient? 81 years old. 83, somebody said? He's 83. I apologize. He's 83 years old. 83-year-old man getting this back surgery done. Why? Because he wants quality of life. That's what we do here at Duke Spine. We give people back their quality of life. How do we do it? By fixing the source of their back and leg pain. Why can't other doctors do it? Well, they don't have the training, they don't have the equipment, and they don't have the technology to do it. Unfortunately, even the most advanced spine centers like the Cleveland Clinic and the Mayo Clinic, they're literally 30 years behind this technology. The only people close are in places like Korea, South Korea, and possibly in Phoenix, Arizona. There's one location where I was trained, but not with the laser. The laser is unique to Duke Spine. But you're not going to find this surgery everywhere, unfortunately. It's literally in small pockets. You're going to have to travel to Florida to Duke Spine Institute. Any questions from our audience? These are all pieces of herniation, by the way, coming out.
No current questions.
Very good. Let's go ahead and run our video, Henry, on how this Duke laser disc repair does its job, how it works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Hey, can switch the lights, please? Switch the lights.
All right, you guys see the herniation we just took out? It's a nice little piece right here.
Yes, we do.
All right.
All right, thank you.
So welcome back. I was just finding out from Luis what business he works at on the weekend. Huh? A stripper? You strip floors? So some people ask me, why, Dr. Duke, doesn't that laser get super hot and melt and burn? Here's the thing, guys. Out there on the internet is a lot of false information. Laser surgery that you're watching right now is so revolutionary and earth-shattering that all the other spine surgeons out there are very, very scared because they don't know how to do it and they don't have the resources to buy all the equipment and train the staff and learn how to do it. So they're out there bad-mouthing laser surgery, okay? Even though they've never done it themselves. And the only thing they're saying is, oh, lasers, you get hot and so it can burn you. They're lying. You can't burn something that's underwater. And not only that, but this is cold water. So we keep everything nice and cool, okay? I had a funny comment the other day on one of my YouTube videos where I was complaining about the irrigation not being cold. And somebody made a comment, that's right, Dr. Duke. You let them know what you want. So long story short, what I'm getting at is that the details here of the surgery are, there's a lot of details that go on in this surgery that I talk about some of them when I can, but there's things that also pop up when there's a problem and then we realize the details aren't right. For example, if the irrigation isn't cold, okay? It's very important because the laser will get hot and it literally can burn tissue if you don't have it submerged in cool liquid, okay? But the same thing happens with drills, right? Everyone's used a drill before, and you know, you're drilling a piece of wood. If you just keep drilling it, it could start a fire because of the frictional forces create heat energy. You see people drilling metal all the time. They use oil as a lubricant, right? And the drill bit is constantly bathed in oil. Well, the same thing with a laser. It's no different. We have to, oh, there's a piece of herniation right there. Just came out of the annular tear. Okay, what we talk about all the time. The annular tear is where the herniation comes out. And this is a big piece of herniation that was literally stuck in the annular tear and just released it with the laser. Still another piece there. I'd say just about 2 more minutes on this disc on this side. And then we're going to switch sides. I'm going to come over there to do that side, Luis.
Yes, sir. Yeah.
Very nice. You can see the inside of the disc right there. Any questions from our audience?
No current questions.
Is our audience aware that they can ask questions?
Yes, they can. Of course.
All right. Well, if you're not going to ask questions, I'll just keep talking. For those of you who'd like apps, Duke Spine Institute has its own app. It's on the iPhone and the Android. You can download it for free. There's no charge. Yeah, he's feeling that. Doctor. So I'm going to wait a minute. Let me have a grabber. I'm going to see if I can grab out a piece of herniation while we're waiting. This is the back of the herniation, by the way, right where it interacts with the neural foramen, where the nerves are. As a matter of fact, what we'll do is we'll try to look and see if we can see one of the nerve roots. So I'm going to turn the tube and scope and look north. North means to the left. There's some more herniation right there. Lots of pieces of herniation coming out. By the way, did you notice that, how the herniation just danced itself out? That's because this laser is very special. Not only does it provide thermal, or not thermal, but delivery of energy like electromagnetic radiation right to the tissue, but it also jiggles the water. So we have a chemical effect, and we have a pressure effect, which is a pulse wave that the laser creates. It's called cavitation. cavitation. It basically generates a massive sound wave underwater.
We have a question.
Sure. If there were dolphins swimming around in here or whales, this sound wave would be communicating to them. That's how powerful it is. But what it does is it creates a shaking or a mechanical agitation. And it really helps with the surgery to get the loose pieces of herniation out. Sure, I'll take the question.
First question comes from Food is Life and Love on YouTube.
Hello there, and welcome. Thanks for joining us.
And they ask, what would be the reaction by the patient as you are close to the root? I think that was from earlier.
So if I'm too close to the nerve root, the patient will say, ow, I have pain shooting down my leg. And then we stop and we redirect to another location.
Our next question comes from Jean Christian on YouTube.
Hello, Jean Christian. Thanks for asking.
And
Thanks for being here.
All good. And they asked, hi, Dr. Duke. Have any studies been done to assess how well the disc heals after a year?
That's a great question. No, there's no studies. And there's no way to know how well the disc heals after a year. Because you can't see it with your eyes. And there's really no test that I'm aware of that will tell me how well the disc is healed. But it's certainly something for the future that we need to look at. It's possible that we could use something like nuclear medicine tests to look at metabolism in the back of the disc to gauge how metabolically active the tissue is. Of course, healing requires metabolically active tissue, but the reality is, and of course when the healing is done, the metabolism slows down. The reality is the disc is so poorly vascularized that healing is very slow. So we're not going to see with those normal metabolic tests that we use to assess healing in other parts of the body, we can't use those tests on the disc. And MRI doesn't tell you if something's healed. So there's really no test that tells you how well healed the annulus is at a year that I'm aware of. So we're just kind of waiting for some tests to be developed maybe in the future. You could, of course, put a scope in there and look, but then you'd be subjecting the patient to an invasive procedure just to assess the healing status, which is, in my mind, it's a very bad idea. All right, just about done. Another 10 seconds, and we're going to be finished here. We're going to move on to the next disc. Let me take a look and see if we can find the nerve root right out here. Well, let's see. I want to get that with the laser right there. That's the last bit of the annular tear. Great question. Any other?
Yes, we have another question from Siva Kumar on YouTube.
Hello, Siva.
And they ask, would the procedure remove the herniated disc both my side at the same time?
Yes. Yes, this procedure would remove the herniated disc as well. That's what we've done. We've removed the herniated disc, both the part of the herniation that's outside of the disc and the part of the herniation that's stuck within the annular tear. A lot of people don't know about that second part of the herniation. It's called the interposed herniation. And to me, it's the more important herniation. All these other doctors are focused on the extruded part, the part that's outside of the disc. That's what everybody looks at and everybody pays attention to, but that's the wrong part to look at. The right part to look at is the part that's inside the tear. It's called the interposed herniation. That's the part that causes back pain and leg pain. All right, take that. Let's see if we can see the nerve root. It's right in that fat there, in that fascia. You see on the left, just to the left, but you can't distinctly see it, which is good. So it's still protected and covered, but we're done here on the left side. at L3-4. We're going to move over to the right side next. Okay? Can you see here, Henry?
Yes, sir.
Okay. So far, we use this 7mm Band-Aid incision to do this Duke laser disc repair on the disc at L3-4. I'm irrigating out some antiseptic. We use antiseptics to make sure there's no infection that occurs afterwards. We've never had an infection with this surgery, but we don't want one. And this is just irrigating. Great questions. Any more questions people have?
Yes, we have another question from Siva on YouTube.
All right, Siva's on fire today.
And they ask, would the procedure treat central canal stenosis while removing the affected disc at the same level?
Would the procedure treat central canal stenosis? Yes. The procedure can also treat central canal stenosis. As a matter of fact, it's the only procedure that can treat all stenosis of the spine. And for those of you who don't know where stenosis occurs, there are 4 places. There's central, there's lateral recess, there's foraminal, and there's extraforaminal. And this procedure can treat central, lateral recess, foraminal, and extraforaminal stenosis.
I think it's fused.
Huh?
I think it's fused. Can you check?
Are you serious?
Check.
Well, I know I hit it. So what we were just talking about is when you have to be careful when you have 2 needles and a disc, because if the laser hits the metal of the second needle just right, you can actually fuse the 2 metals together, and then you can't do the procedure. And so we were just checking that. Did you raise the fluoro?
No, sir.
How did we need the bed to be up. The bed up a small amount, quarter inch. That's good. All right, so we're here on the right side at L3-4. Shot. I placed the guide wire. There, shot. Uh-huh. Shot. So now I'm going to leave the guide wire and take out the needle. But you got to be careful. You can accidentally pull the guide wire out at the same time. Can you show the audience the guide wire and the needle? Can you guys see a difference? So you can see the needle is thicker and it ends right there, and then the guide wire continues. That's what we want. We want to leave the guide wire in the disc, take the needle out. Okay, but you have to be careful because you could pull the guide wire out when you pull the needle out. And can you guys see this?
Yes, we can.
The tip of the needle, do you see how it's been melted?
Yes.
Right there?
Yes.
All right. So if you're not careful, you could actually melt through, and the stylet, which is this thing right here, you guys see this going in? That stylet right there?
Yes, we do.
That's inside the needle. If you're not careful, if you hit it with the laser, you'll weld. You'll literally weld those 2 pieces of metal together. And then you'll have to start over, okay? And I've done that once before, I think. And anyway, you just got to be careful. Okay, 7mm incision, again. This is a Band-Aid incision, tiny, tiny. And the reason why the incision's 7mm is because the outer diameter of the tube I use, this tube right here, this endoscopic tube, this is 7mm wide. So that's all we need. We don't need a wider tube. We don't need a wider incision. You can do everything through that tiny incision. Shot? All right, you can see the tip of the dilator sliding down the guide wire. We're now in the foramen and heading towards the back of the disc where the herniated disc is. Again, this is an 83-year-old patient, okay? We don't believe in denying people medical care because of their age. Other surgeons wouldn't operate on him because he's too old. They say he's too old. He won't be able to survive their spine surgery. It's probably true. But with the Duke laser disc repair, you can operate on anyone because there's no medical restrictions. You just have to do a physical and EKG and some blood work. And as long as your heart is in good enough condition, our anesthesiologist will approve the surgery and move forward safely. Because look, we're not losing blood. We're not doing general anesthesia. There's no intubation. So this is twilight anesthesia. So people can tolerate it very well. You can be sick with diabetes, high blood pressure, other medical conditions, and still get this minimally invasive procedure done.
Safe for lung conditions too?
It's safe for everyone except for Luis, because if I miss, he's not going to be able to do his weekend job. Shot? I think we're in. So again, we went through the tear in the back of the disc, so we're not doing any damage to the normal disc at all. We're literally passing through the damaged part that we're here to fix. That's the beauty of the transforaminal approach, is we go into the disc right where the bad part is. So we're not adding any new damage. Any questions from the audience?
Yes, we have another question from Food is Life and Love on YouTube. And they asked, do you require post-op MRI to visualize your beautiful work post-surgery?
Yes, great question. No, there's no post-op MRI done. You don't need an MRI. MRIs are ordered when you want to change the treatment plan so that you can do an assessment of what's going on and then make treatment decisions based on that. With the post-op patients, they have no pain, they have no symptoms. There's no reason to get an MRI scan. It would be a waste. And we're not looking to make the spine normal. There's no treatment in the world available that makes your spine back to how it was before you had any injuries. So that's an unrealistic expectation. And nobody promises the spine is going to look normal. So the MRI is not going to show you anything. MRIs don't show where pain comes from. That's what the doctor has to figure out. Unfortunately, that's why there's so many people in pain, because the doctors order MRIs and they think the MRI is going to show them where the pain comes from, but it doesn't. So MRIs are only useful when a patient has symptoms that are related to an abnormality on the MRI that can be seen on the MRI, which is pretty much everybody before they have surgery that has disc pain and a herniated disc. But after surgery, there's no reason to get an MRI. It doesn't improve the outcome or treatment or do anything. Getting an MRI after a successful surgery that eliminates your symptoms is totally unnecessary and not helpful in any way. So we don't order MRIs. We're not taking a brain tumor out. If you were taking a brain tumor out of someone's head, you'd want to make sure the tumor's gone. And that's why you get an MRI, because if you don't get rid of the tumor, it's going to grow back and it's going to come back again. And they're going to have another surgery. So making sure you get a brain tumor out is important, and that's why you get an MRI afterwards. Thank God we're not taking brain tumors out here. Great questions. Any other questions?
no current questions, but we do have a comment from Food is Life, and they said, thank you kindly for answering. Makes sense.
Yeah, good. Yeah, food is life. You must like food. That would be like having your friends come over, eat your dinner, and they say, hey, that was amazing, I'm full. And then you say, well, let's get an MRI of your stomach to make sure you're full. Right? Well, that MRI of the stomach isn't going to tell you if they're full or not. They're going to tell you if they're full. So, same thing with fixing back pain and neck pain. The patient will tell you if you got it right.
You need a PET scan to look at the satiety center.
Right.
See if it lights up.
Right, but then you could argue, is it physiologically full or is it structurally full? And if it's structurally full, if you see an air pocket, then is it really full? Or do you consider air not being part of being full? Because people have air in their stomach. So it gets into a very complicated, weird stuff that's no point. It's just chasing ghosts. How are we doing on irrigation? You guys see all the debris coming up when I hit the herniation? The water gets cloudy. The reason it's cloudy right there is because there's all these little pieces of herniation that the laser's releasing. And that's why you can't see that well. It becomes cloudy. All right, 5 minutes, maybe 8 minutes maximum, and we'll be done here with the DLDR. Sure? Yeah, I think you should. I could tell the irrigation was getting less because I'm getting more debris obscuration.
Doctor, remember that we're going to do the DPR after this.
Yeah. So we're going to be doing a Duke plasma rhizotomy next on this patient. We're not going to broadcast it, not yet. But we will soon, I promise. It's just a matter of time. And you can actually see the tear right here, folks. Look at that annular tear. That's the tear in the annulus right there. And that blue stuff is the herniation stuck in the tear. This is what causes all the back pain and leg pain. It's called the interposed herniation. Most spine surgeons don't even treat this. 99% of them won't treat this because they don't know that this is the cause of back pain. I've been trying to tell them for 16 years. They just don't listen.
We have another question.
Sure.
This comes from Jean Christian on YouTube.
Uh-huh.
And they asked, when you push through the annulus, does that leave an opening for some time and risk of future extrusion?
Great question. And we are pushing through the annulus, but we're pushing through a tear that's already in the annulus. Okay? So we're not making a new tear in the annulus. We're going through one that's already there. The door is already open. And that's why, no, it doesn't. If anything, this procedure is doing one thing. It's cleaning the tear and allowing the tear to heal properly. You see this stuff right here? That's what's keeping your tear from healing. I'm removing it with the laser. So this surgery is the only surgery in the world that allows the annular tear to heal. Every other surgery destroys the disc or leaves the tear there for more herniations to happen, and therefore more surgery to happen in your future.
We have another question.
Yeah, do you have the microdiscectomy video you could run?
I do not believe so.
I need you to load that so you could show people what a microdiscectomy does.
Copy that, sir. No problem.
That's on the animation video list.
Yes, sir. I'll get right on that after this.
Thank you.
And we have another question. This comes from Donald Seeger on YouTube. And they asked, can the procedure be done on patients with prior laminectomy or fusion?
Yes, Donald, the procedure can be done on patients with prior laminectomy or fusion, or both. Absolutely. We do it all the time. We have lots of our patients. If you go back and watch our surgery videos, you'll see many of them have had laminectomies or fusions already elsewhere, and they're still in pain. So they come here and they get the Duke laser disc repair done. So yes, you can have it done. By the way, if you're interested in being evaluated for Duke laser disc repair, We have a free MRI review that can be done, and that is mri.dukespine.com. Would you please put that address on the site so everyone can see it?
Copy that.
Once again, I was talking earlier about the Duke Spine Institute app. It's on the app stores in Apple as well as Android, and it's free. There's no charge. It has lots of good content that you'll enjoy. You can learn a lot, and I recommend you check it out.
We have another question.
Yes.
This comes from Siva Kumar on YouTube, once more. And they asked, is there any radiation exposure from the laser disc repair?
Great question. Is there any radiation exposure from the Duke laser disc repair? There is, because we use the X-ray machine in the operating room to localize and navigate to the disc, but it's very minimal. Far less than traditional surgery. Far less. As a matter of fact, it's around, we need to look at that. Arias? Is Arias there?
Yes, he is.
Arias. That's another paper that we need to publish. Radiation exposure during Duke laser disc repair versus lumbar fusion or ACDF. I forgot about that. Very important paper. Jordan, have you been keeping track of the amount of radiation? You're going to start. Okay. Yeah, because I know we've kept track of it for the fusions in the past. All right, so the amount of radiation exposure you're going to get for a fusion surgery is around 3 minutes to 5 minutes. But with the Duke laser disc repair, it's around 5 seconds of radiation exposure. So far less. But there is a small amount because we are using a fluoro machine, which is an X-ray machine. Produces X-rays. Yeah. Well, remember, we still have the plasma to do. Right? You're not going anywhere, are you?
Where to go?
There's lots of places to go.
Universal.
Were you? You were there for the weekend?
No,
Oh. When were you there?
I've never been there.
Oh, I thought you said Universal. You want to go to...
No, it's just
messing with me?
lots of places to go.
Oh, yeah, there's lots of places. Do you like roller coasters?
No.
I'm going to say. You've been on the...
My wife's the only one in the family. Right,
Yeah. Yeah. Anybody else here been on the Velocicoaster over at Universal? You have? You like it? I haven't been in a while. Which one, Hulk? Come on, seriously? You were on Velocicoaster and you like Hulk better? Hulk is good. Yeah, but you get launched twice in Velocicoaster. Even better than Hulk. That second launch is crazy. Have you been in the front seat? Oh, you'd remember. The front seat's extra 15 minutes. It's worth every second you wait. It's amazing. You got to do the front seat launch. Try that. Go back and do the front seat. I promise you. You'll never go back to the Hulk again. That's like eating at McDonald's versus eating at Ruth Chris Steakhouse. Yeah, it's fine. Irrigation's good. Right? All right, just about done here, folks. And then we're going to, we'll take any other questions you have right now. I know the next surgery today is a plasma rhizotomy. Again, we're not broadcasting. So this will be our only surgery today. We're broadcasting live for you to watch and learn. Now this patient's going to go home in about 45 minutes, okay? This is an outpatient surgery. Nobody stays in the hospital. There's no hospitalization. There's no painkillers. There's just Tylenol, usually for a night. And that's it. So, yep.
We
Go-
ha-
Yep, go ahead.
yes, we have a question from Jean Christian once more.
All
And-
right.
And they asked, how
30 seconds.
do you know that the discs heal if no post-studies were conducted?
Because the patients don't get reherniations, and they end up out of pain, no pain. So we know the disc is healed. How do you know anything is healed with surgery? We don't go and get studies done on every surgery we do. Whether you're having a laminectomy or a discectomy, which are horrible procedures, by the way, or you're having a fusion, there's no way to know that the tissues have healed properly. Okay? The only thing you can really know is through indirect evidence. And that's pretty common in medicine. We don't have a test for every healing. As a matter of fact, the vast majority of healing there is no test for. Maybe 1% of healing of the human body there's a test for. The other 99% there is no test for. What matters is the patient's back pain is gone permanently, and their leg symptoms are gone. That's what these people want. They don't want MRIs and CAT scans and tests. They want results. And for too long, doctors have used tests to judge their results rather than patient outcomes. The best test is the patient telling you their back pain is gone. And that's what all of our patients end up with, is their back pain being gone. Okay? Now, there's other causes of back pain besides the disc. So you have to make sure the patient doesn't have a secondary or third cause of back pain. Because there's 32 causes of back pain in the human body, 32 possible causes. Some people have 2 or 3 or 4, some people have 1. And the vast majority of patients have more than one cause of their back pain, right? This patient has their herniated disc at 3-4, and they have the facet joints at 4-5 and 5-1. So if I don't treat all those causes, their back pain will still be there. Part of it will still be there. So the best test is the patient telling you that their symptoms are gone. After all, back pain is a subjective thing. All right, any other questions? These are great questions.
No current questions.
We are done with the laser part of the surgery. Now we're going to do the plasma for the facets. So if you have any questions, this will be the time to type them up, as we're going to stop the live stream so we can do the other parts of their surgery. I will say this patient not only has the bad disc at 3-4 causing back pain, but also the facets at L4-5, L5S1 on the right side. And they also have what's called a piriformis syndrome, which is a torn muscle in the buttock right here. And Dr. Patel is going to come in and do the piriformis injection to relieve the pain in their buttock. I need the dilator. All right. Any questions?
No current questions.
Excellent. Well, thank you for watching, and we're going to go ahead and, let me show you the incision so you all could see how small the incision is. I'm going to take this out first, and then we'll show you the incision. Give me a second. It's important when you take the tube out that, remember, you pass through muscles, so you want to apply a little bit of pressure to the muscle and make sure there's no bleeding. If there is a little bit of bleeding going on in that muscle, then the patient will have some muscle pain, usually for a few days to even a few months, depending on how much bleeding there was. So the way you keep the bleeding down in the muscle, obviously, is this surgery is very good about that, because you're not cutting the muscle, you're spreading it. You're spreading the muscle fibers with the dilator.
Oscar, can you take these to the soil room, please? Thank you.
So just to remind you, this is the dilator. You all see this?
Yes, we do.
So the tip here, this tip, spreads fibers apart. Fibers, okay? We're not cutting the muscle, we're spreading the fibers. But sometimes you'll get a little vein in there that gets torn, and it can bleed. And the other thing you have to do as a surgeon is make sure your anesthesiologist keeps the blood pressure around 110. Systolic, you don't want to go over 110. Maybe 120 is okay, but you want to keep it around 100 to 110. Systolic, okay? And the reason is if you let the blood pressure go up to 190 or 180 or 170, then you're going to get more bleeding. So blood pressure control is very important during these surgeries. All right, take a look here. That's your incision, folks. Look at that. This is only possible with endoscopic spine surgery, the Duke laser disc repair. Other surgeries require big cuts on your back, damage to your muscles while the surgeon gets down to the spine, pulling ligaments out of your spine, pulling bone out of your spine, pulling joints out of your spine. All that damage is just standard for surgeons. They don't care because that's how they were taught to do it, you know? But the truth is the patient has to live with the consequences of that bad open back surgery, laminectomy, discectomy, fusion, artificial disc. All those surgeries damage your body. And you get scar tissue, you get trauma to your body, and it manifests itself as pain after surgery. You'll feel horrible pain. That's why they put you on painkillers. With this surgery, there's no painkillers. Just Tylenol for one night. All right. Thanks for joining us. If there's no more questions, we're going to stop the live stream. We're going to just keep recording.
No current questions.
Have a nice day.